Okay, guys, thanks for coming up today or in today. You guys know me by now. My name is Gunter. I'm doing this. This is my second lecture of 3 lectures that we have to do for our EMS methodology class or instructor methodology class. Can you guys see this, or do I have to hit the lights? It's pretty much a white background the whole time. Okay. So I know this is a review. Ken taught your airway class. I love capnography. This is why we had to pick, I think we had like 20 topics we could pick from, and I chose to do capnography because I absolutely love capnography on a truck. It's right up there with my blood pressure. I'm sure my supervisors love it because I go through some serious end titles. And they're not cheap. So this is just a little comic that apparently I thought was way funnier last night. Today it's not so funny.
It's fine.
So capnography shows the carbon dioxide content of expired gases at the end of the expiration phase of respiration. Yes, I know, this has got like 20 slides today. I'm going to try not to kill you with PowerPoint. Capnography consists of a number and a graph, right? You've got the y-axis is the length, which depicts the time or duration of the breath. And you have the x-axis, which is the height or amplitude that shows the amount of CO2 that the person is blowing off. You have capnometry, because apparently I can't speak this morning, which is the partial pressure of CO2 detected at the end of exhalation. This is the end tidal, which is normally between 35 and 45. You guys probably know that. Capnograph is the waveform that you get. Okay. If you guys have any questions, or you guys want to add anything while we're doing this, I urge you please just raise your hand. I'll be more than happy to call on you. I hope you guys by now have seen the 2 different types of, these are the 2 that my service carries. You've got the one, it's advanced airway adapter, they call it certain something sensor. It fits on the end of any advanced airway or the ET tube. And then you've got, this is my favorite guy right here, the nasal prong one. And the ones at my service have that little cool bubble lip thing on the end of it. Yeah, exactly right there. So those are typically what you'll see, but there are a ton different on the market. So has anybody here run a code yet? And during clinicals, have you used your end tidal? Okay, I hope so. It's pretty much standard for our service now. But so you've got 4 phases of end tidal CO2 of capnography. You've got the respiratory baseline, which is this, which is basically nothing going on. Then you've got the expiratory upstroke, which is there's no carbon dioxide at the beginning. It kind of flies through the upper airway dead space. It's just you pulling in that oxygen. And there's no gas exchange in your upper airway. So, yes, thank you, ma'am. Expiratory plateau is the sensor receiving the CO2 rich. Uh-oh. Just stick it back in that. There we go. Perfect. Okay. Thank you so much. I'm so glad I didn't. The rich O2 gas that was in the alveoli. It's the stable amount, so that's usually why there's a plateau, obviously, right? And then you have an inspiratory adaptive stroke patient breathes in the oxygen again, and obviously there's no CO2 in it, so it kind of plummets rapidly. That's why you get such steep rises and falls, in and out. All right, because we don't have enough OPQRSTs and all that good stuff to remember, here's one more. I didn't even learn this when I learned capnography, so I thought it was kind of cool, and this is why I threw it in here. You got proper, which is the understanding of normal readings and shapes of end tidal CO2. So you guys, obviously know what the waveform's supposed to look like, know what the end tidal number is supposed to be. You get the quality. You're looking for, or the quantity, excuse me. You're looking for 35 to 45, as always. You've got the rate of ventilation for the patient. Hopefully it's not too fast, not too slow. You've got the shape, which is the normal shape of a waveform. And then you've got the trending, which is all of it put together. The quantity, the rate, the shape of end tidal, and hopefully it should stay stable or it should improve. If you guys are putting it on, you're putting it on for a reason, right? Alright, ventilation versus oxygenation. I'm sure you guys have totally figured this out by now, but your SpO2 or your pulse oximetry is measuring your oxygenation. It's measuring how much hemoglobin or how much oxygen is loaded onto the hemoglobin to take it throughout the body. And then capnography measures your ventilation, which addresses clearing the CO2 from the blood. So I love end-tidal CO2 for lots of different reasons. For one, you don't just use it on respiratory patients. You can use it on stroke patients. You can use it on overdose patients. You can use it on anybody that you can't figure out what's wrong with them. It's just another, tool in your handbag to try to tell the doc, hey, look, I got no idea, but this is the vital signs that I got, because they don't check CO2 right away. Their end-tidal CO2. They don't monitor that as close in the hospital. They do it with ABGs. So, when you use your SpO2 sensor, it's not going to change very rapidly. Your patient can start deteriorating long before you ever really figure it out. With your ventilation and your end-tidal CO2, the change is extremely quick. You'll know within 10 seconds. So what would you rather know when you're very first day on the truck with your brand new basic partner and you've been a paramedic all of 10 seconds and somebody hands you the NARC keys and says, go to town. And you're scared for your first bad, sick, critically ill patient, and you have to try to figure, and nobody can tell you what's wrong with them. Maybe it was a welfare check the sheriff's office did. And they find this person lying on the floor and they have no idea how long they've been there, why they're there, who they are, what they are. So, I use it just as to trend my patients. So this is where we're going to get into some of the different uses for capnography. You got hyperventilation, hypoventilation, you got apnea, you got bronchoconstriction, cardiac arrest, or more likely when you get ROSC, and your elevated baseline. So the biggest one, I'm sure, because Ken taught your airway class, was that he drove home your tube conformation. If any of you have seen, I'm sure they do it at other services, but the service that I work at, if you've seen when we take in a code, and it's a workable code, or maybe they got ROSC on it, there is one little box under our signature things. Usually the nurse will sign twice. There's one more, and it says airway confirmation signature. And that's usually when you have to hang around and wait for a doctor for an x-ray to come in, for them to x-ray the patient and confirm your tube placement. They may do it other ways, but in my experience, I've always had to have a portable x-ray come, do a quick x-ray. The doctor will look at it, see if he's happy or not with it, and then he'll sign for me. So huge, 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 huge. If you do it for nothing else after what I told you today, please, please, please do it for that. Do it every time. So, you've got hyperventilation, right? You've got your potential causes. Hyperventilation syndrome. Hey babe. Very excited bagging, all right, and a pulmonary embolism. Okay. Hyperventilation syndrome. Some people just like to breathe fast. Some people get into it for all different kinds of reasons as to why they breathe so fast. Could be just anxiety, could be lots of other things. The second one is my favorite. Hey babe, you get very excited, anybody. We always used to blame the firefighters. If you were ever on our truck back a couple years ago, we had these little things, they were plastic, they looked like a tennis ball, and they had the little adapter on the end that fit on the end of the ET tube, and then your bag fit on top of that. And all that big pod did was it would light up every 6 seconds. And so that way the person that was bagging the patient said, 2, 3, 4, 5, 6. Oh, and so you could literally put anybody to bag your patient. But it was very helpful during a code, because if you have not yet ran a code, you will realize very quickly, especially if you are the only medic there, and once you realize you are the only medic there, that there is a ton of stuff going on. And trying to figure out if Ricky Bobby is bagging too fast is one of the last things that you'll realize. So, this helps to show, hi, that your partner or whoever is going too fast. They don't like to be told how to do things. Some people, it doesn't matter who it is, firefighters, law enforcement, bystander, sometimes people just don't want to. With capnography though, you're able to be like, hey man, see that waveform right there? It's too short, it's too narrow, I need you to lengthen it out for me. Slow down just a little bit. And then your pulmonary embolism, obviously, because, you know, the patient can't breathe, so they're going to be breathing quicker because they're panicking because they can't breathe. Alright, hypoventilation, alright? So, your possible causes of this are as follows. You've got respiratory depression, which of course could go hand in hand with narcotic use, could not. You've got CNS dysfunction. You've got heavy sedation. You've got drug or alcohol use. You've got a stroke or a head injury. So really narrowing it down on that patient that you have absolutely no clue what's wrong with them, right? If they're hypoventilating when you get them in the truck, hopefully you've maybe thought about Narcan. Hopefully you've maybe thought about trying to do a stroke screen on them if they're able. Maybe you've done a scene assessment, trying to figure out exactly what's going on, right? So, apnea. Your possible causes of apnea. This is pretty much what it'll look like. I love how we use these kind of examples, and then when you get on the truck, and if you ever actually print out an end tidal strip, the actual baseline waveform of somebody with an end tidal of like 38 is probably about that long. If they're this short, usually it's hyperventilation on an actual true blue strip. So, let's talk about apnea for a second. Possible causes of it is a dislodged ET tube. You could have obstruction of the ET tube. You could have fluid, mucus, stomach contents, whatever. Your equipment could not be functioning properly. Grandma could have pulled the prongs out of her nose accidentally trying to wipe her nose or something like that. Or, hey, that's cool, you decided to sit in the captain's seat with this patient. You've had a lot of runs, right? You're kind of really tired, and all of a sudden you look up and the alarms are going off, and maybe your patient's in arrest, respiratory arrest. So, has anybody heard of Drew's movement ever? Okay. So when I was in school, I learned about Drew's movement, and my thing in EMS is if you don't learn about where you've been, you'll never be able to go forward. So I have this kind of half-long article that I'm going to read to you guys because it is incredibly, incredibly important for you guys to understand how important tube movement and possibility of dislodgement is when you are running a code or transferring a code. And you guys need to understand to pay attention to your capnography for apnea, which is your first line of defense against, hey, maybe we need to go back and double check things. So, Drew's movement. Drew Hughes was only 13 years old when he died after his endotracheal tube was accidentally dislodged during transport to a level 1 trauma center following a skateboarding accident. The transport team, which included a respiratory therapist, accidentally re-intubated Drew in his esophagus and did not recognize the malposition as they did not carry an end-tidal CO2 detector with them. Drew's oxygen levels fell and his heart rate slowed. The transport crew quickly diverted to the nearest hospital, but it was too late. Drew had already suffered from anoxic brain injury and eventually did die. The Society for Airway Management and the Patient Safety Movement Foundation are leading a multi-organization effort aimed at spreading the word about the best practices that are needed to make deaths like Drew's a thing of the past.
I met his mom and dad.
His mom and dad?
I met his mom and dad.
Oh, you did meet his mom?
And I have the disposition of the paramedic for that call.
Really?
Absolutely. From Drew's dad.
Wow. The American Association for Respiratory Care is a key member of the Coalition for Unplanned Extubation Awareness and Prevention. June 29th this year, it's only been 6 years since Drew's passed. So we're not talking like this happened like years ago and they intubated them, they didn't have the technology yet, they had the technology. You guys all have the technology. The association is urging respiratory therapists everywhere to read Drew's story and take proactive measures in their facilities to prevent unplanned extubations from occurring. So just keep that in the back of your head. When you guys have intubated patients, you can just flick the end of an ET tube and it can become dislodged. Okay? That's not counting when you're trying to continually bag the patient and walk them out of the back of the truck and you've got 15 people trying to help your stretcher out. Everybody's in a panic because there's a code or you've got rust and they want to keep it and they want to get that safe in, and that's great. But just remember, slow and steady when it comes to this stuff, okay? And capnography is your best 10s. 10 seconds versus 5 minutes with SpO2, right? So you've got bronchoconstriction. This is my absolute favorite, why I use it on the truck. I can't hear. When we are rumbling down the road, I can't hear, okay? Everybody yells at me because I'm so loud all the time. It's because I have hearing loss. So unless I'm sitting still in a quiet room or the quiet back of the truck before we get rolling, I can't hear. So when I have a bad respiratory patient, I will listen when I'm able, but once we get in the truck and we get rolling, I use the end-tidal CO2 to evaluate everything I have, right? How good my treatments are working, if my patient's going to start deteriorating, if maybe I need to do a couple more things. How many patients out there, how many patients have you guys run as in clinicals where they have the, respiratory trifecta? COPD, emphysema, and CHF. Yeah, right? So, big fear with treating somebody with COPD or emphysema and CHF, right? They're constricted, right? So we're going to give them albuterol. We might even give them a duoneb, right? We're going to open them up. What happens if that introduces fluid into the lungs? They're going to slam shut, right? So you guys have always got to be on it that you make sure that you are ready with that CPAP. You may not have to have it out, but you sure better know how that circuit works, right? And fast, okay? So bronchoconstriction is what I use it for. Asthma, COPD, CHF, airway obstruction, or partial airway obstruction, not total. Obviously, if it was total, it would be apnea, right? Or obstruction of equipment. Sometimes you get patients that get a little, like you get mucus somewhere it's not supposed to be. I mean, that's fun, right? But you use it for that. It's very, I love it. Usually I like it because it makes me feel all warm and fuzzy inside when I get to watch the patient improve. You get to slowly watch those shark fins become just nice, almost regular waves. And it's nice to take into the doctor and say, hey, this is initially the end-tidal strip that I got with them, and this is what I got now, right? So, poor perfusion. When you guys are on a code, working it, doing your thing, and you're busy, you may not have enough help, but you may have enough help, right? Actually, how many firefighters are on a code, right? Like 9?
It depends on the station.
Exactly, but typically everybody likes to come out of the woodwork. They all want to have a hand in it. And usually it's your firefighters that end up doing compressions because we love them so much. So, we have the pads that have the little diamond on them that you have to fill up that diamond. You tell whoever's doing your compressions, look at that diamond, fill that thing every time you go compress the chest. If you're not filling up the diamond, either do it harder, faster, or stronger, or tag out with somebody else and have them come in that can fill the diamond up, right? If you don't go to a service that doesn't have that diamond type, those indicators and those type of pads, you can use your end-tidal CO2. So what happens is, right, you're compressing, having good perfusion, right? You even have some gas exchange because you guys are doing such good compressions. And then all of a sudden, whoop, nothing. This is, let's fast forward and maybe say it's 3-4 minutes, right? 5, all of a sudden, none. Okay, all right, I need somebody to swap out, right? And then you go right back to, hopefully to this, to adequate perfusion again with your compressions, okay? So you guys can use that to your advantage on that. And then ROSC, during a CPO, or during a cardiac arrest, this is the best thing ever. Because, you know, you don't want to constantly stop compressions to try to check for a pulse. And how well can you assess a carotid pulse when somebody is beating on somebody's chest? Not very good. Even if they're using a lupus, which is more of a, you know, a direct compression, it still shakes the patient around and it's very hard, especially when you're rolling down the road. Rolling down the road, which you typically should not be doing in a cardiac arrest, but if it happens, and all of a sudden you're going along and all of a sudden you see this, you keep going, right? You're gonna do another 2 minutes. But then you can check. If your end tidal is still like that, you might have pulses back, right? So, good day, right? Hopefully they're neurologically intact at that point and you give them a hospital. Rounding it out. So, elevated baseline. I haven't typically seen this. I don't know if I'm just not that lucky or I just haven't experienced it yet, but it does, when I was looking at videos last night, it does pretty much look like this, which is a little strange. Usually it's some kind of rebreathing, right? You're not blowing off all of the CO2, you're kind of getting back, you're getting a little bit more CO2 in with your oxygen. So you got, it could be your oxygen mask, your forehead and shoulder alignment, shallow breathing. You got air trap or bronchoconstriction patients. And then this one is more of a critical care issue because it means something's wrong with your ventilator, but it's the CO2 rebreathing. If you guys ever go on to critical care, which I hope some of you do, you'll see that a lot. So, ICP fun facts. So it used to be hyperventilation. Yes.
That's air trap. What are you referring to?
Air trap and bronchoconstriction patients, like COPDers that can't. They may not be able. If we haven't treated them yet, and they're not able to open up all the way to release all that CO2 off. So it used to be ICP, head injury patients, hyperventilate. You'd grab a bag and you'd say, "You go to town. Just quick breathe for them. Do me a favor." They've now said, "Stop that." End tidal CO2 has, and many studies been done on head injury patients. Tragically, the military is some of the leading forefront of these studies because of so many TBIs and blast injuries and all that stuff. Attempting to ventilate a patient with possible ICP needs to be done extremely carefully. Whoever you're putting on that bag, if you choose to intubate that patient, needs to understand this method behind the madness, okay? Hopefully this is a day where you are able to be with a paramedic partner, all right? Because somebody may need to take that extra couple seconds and explain to somebody exactly what they need to do, okay? So, it's a delicate balance, actually, now they've found out between end tidal CO2 and mean arterial pressure on blood pressure. So, they want a map of greater than 65, and they want to realize that people are going hypotensive before they're actually getting hypotensive. Trying to keep the cart before the horse, if that makes any sense. So they want you to ride the end tidal CO2 right around 35, the low end of what they call normal or stable, right? This is a lot of fancy stuff. Eucapnia is the state of carbon dioxide that's at an optimal level, right? 35 is where you want. They may have what this is trying to say is they may have a mean arterial pressure of only 50, but they want it greater than 65. So you may think, well, they've got a systolic blood pressure of 100, they're doing okay. They want you to keep that map at 65 or greater, but somewhere keep it around 60. It says 65, right, greater or equal to. So keep it around there and keep their end tidal around 35. There's a delicate balance. Typically, we're lucky enough in this area, in the service that I work at, that usually somebody will be on a bird, right, by the time we got to start worrying about all this stuff. But some of you guys will not have that luxury. You'll be stuck with a patient for an hour, hour and a half, wherever you may end up working, okay? So, I don't know if you guys can see this. It's just a quick slide about different factors that affect end-tidal CO2, your metabolism, your respiratory system, your circulatory system, and the medications. You've got hypothermia, hyperthermia. Hyperthermia is elevated end-tidal, and hypo is lowered. This is actually, I have a field guide. Have anybody showed you any of their field guides at work? A lot of us carry them, we just don't really look them out a lot. You can buy these little itty bitty field guides, and a lot of us stick them in our pocket or have them in our bags that we carry with us on the trucks. And I flipped through it last night. Mine's in the back of the room, actually, I brought it with me. And there's actually a whole little thing in there about all like different quick reference guide of like different waveforms in case you're sitting there and you're like, what is that? I don't remember. It's just been a really long night and you can't recall your information like you had hoped. All right, so I found this really cool article last night late, and so I decided to talk about it for a minute because pediatrics are incredibly hard to assess sometimes. So they've come up with some of these kind of things. You read them and you're like, yeah, duh, you do that for an adult too. But kids are scary. Really sick kids are terrifying. I've been doing this a hot minute, and I don't like running pediatric calls. Luckily, a lot of people overreact. So when we get there, it's not usually typically as bad as you think. But don't ever let the goose get you, because you start thinking, oh, it's not. So altered mental status, seizures, head injuries, and overdoses are common causes of altered mental status, right? Pediatric patients that can cause airway compromise or hypoventilation. Right? Okay. Somebody gets into grandma's drugs. There you have it. Somebody seized in their bedroom and their mom didn't see it and doesn't understand what's going on. There you have it. Airway and ventilation compromise. So, like kids are hard to intubate, right? We don't do it enough at all, ever. So when you have to recall that skills, right, you're kind of behind the 8 ball. You've got to pad the shoulders, do the certain tilt, chin lifts, all that good stuff. Keep them more in a, I can't think of the word right now. What? Yeah, just a little bit, not too much, but yes. Trying to get them back a little bit. Right, and 12 to 20 breaths a minute. It goes up a little bit more for children, and it goes up even a little bit more for infants, right? Respiratory distress. Hopefully, you can, if they are in respiratory distress, you can get them to keep that capnography on their face. Good luck, though, right? If I try to put it on her right now, she'd just rip it out. And then try to stick it somewhere. So, and then you got your cardiac arrest, right? Obviously, you can save yourself from pausing, right? Every couple minutes to check for a pulse if you think you might have one. Also, in cardiac arrest, if you ever, God forbid, have to run a child, you want to be able to keep going, and you want to be able to make sure your I's are dotted and your T's are crossed, right? So if you have your end-tidal CO2, and there's nothing there, right? It's the same, it hasn't changed, and you guys have been on scene sweating bullets and working this thing for an hour and 15, hour and 20 minutes, way longer than we would ever work an adult, because there is a mother screaming and crying in the corner. Capnography is one of those things that lets you know, like, yes, this may be working, yes, we may have light at the end of this tunnel, or no, or this is going to be futile, like this is going to go bad. This is not going to end well for anybody, right? And then shock. So there was a study done, and like, you guys can't see the little reference that I gave to the article that it was. But a study of children with dehydration from vomiting, diarrhea, right? How many kids get the stomach bug? They found that an end-tidal CO2 level less than 31 correlated with positive blood tests for metabolic acidosis and the need for IV resuscitation, right? If a kid's vomiting and diarrhea, if we're vomiting diarrhea, we obviously already know that we need fluid, right? But I thought it was kind of neat that they did a study that they found that anything under 31 was like, hey, you guys might want to throw them some fluid. Yeah.
So is that like, statistically speaking, what's the percentage or the ratio that study? Like, is it 100% across the board?
I do not know. That's a good question. My question to this was, what age of children did they use? Because when I looked at the article that I found this in, that was the one like snippet that he took out and put in there. So like, yeah, exactly. What was your pool of people that you used? Were they infants? Were they toddlers? Were they school age? So yeah, that was a question I had too, but I think I threw it up there just to try to enlighten you with some extra skills. So luckily we went 31 minutes. Do you guys have any questions? I know this was kind of all a hodgepodge revamp of airway class.
Yeah, I just asked my question.
It's like, no, I just asked my question. So one last thing I want to talk about is seizure management on patients, using end-tidal for seizure management, right? Seizures, if you don't go to one where they tell you, patient's probably at status epilepticus, they're having continuous seizures back to back to back to back. You may throw a patient in your truck and say, wow, I don't feel good. And you're like, okay, well, I've done 12 lead, I've done a 4 lead, I've got your blood pressure, I got your end-tidal, I got your blood sugar, I've done this, I've done that, and I can't find anything wrong with you, right? So you guys are sitting in the captain's seat, we all do it, right? Doing our chart, going on the road, and all of a sudden your patient starts having a huge tonic-clonic grand mal seizure in the back of your truck. Well, that came out of nowhere, right? They didn't tell you they have any kind of seizure history. They're not on any meds for any kind of seizure history. So end-tidal will let you know quickly if they're not breathing, right? End-tidal is obviously going to tell you, right? Within what, 10 seconds, like I told you? So it will let you know whether or not, hey, I need to drive home, I need to go grab the Versed and hit them, or hey, maybe let them just ride it out. If their ventilatory drive and the system isn't impacted, you can maybe be able to err on the side of caution. They clench down and stop breathing, and they're continuing going on in 10 seconds, and you're like, okay, I need you to breathe. You probably need to push some Versed or Valium on them. You know what I mean? You probably need to get them back. And end-tidal will let you tell that, because in the back of the truck, when you're rolling down the road and the patient's shimmy and shaking, and they're already having a seizure, they may be coming out of it, and you can't tell. You breathing? I mean, we don't carry mirrors, right? We're like, so your end-tidal is one way to be like, hey, yeah, cool, okay. They are, they aren't. Like I can ride this out on a more hands-off, laissez-faire type thing, or like no. I need Versed, I might need a fire department, I might need to end up intubating this patient, like depending upon what's going on. So, guys, I can't thank you enough for your time.